Well, welcome everybody to this session on People First, how a community can accelerate the end of HIV transmission. My name's John Rule. I work as the Senior Research Manager for the National Association of People Living with HIV Australia. We acknowledge that we're on Aboriginal land, the Gadigal people of the Eora Nation. I acknowledge any Aboriginal and Torres Strait Islander people in the room, and I know there are some here. I'd also like to acknowledge those who have died because of HIV. I asked Brittany to bring some candles to put in front of our stage here. I want to do that because I'd also like to acknowledge all those people who have offered their bodies in clinical trials, better treatments, and all those who currently offer their life experiences of HIV for better understanding of what living with the condition means. And I also acknowledge all the people in the room who are living with HIV, like myself. Some preliminary remarks. In 2021, it was estimated that there were 29,000 people with HIV in Australia. Of these 29,000, an estimated 91% were diagnosed by the end of 2021. The research shows us that 92% of people who are diagnosed are on treatments, and that of those on treatments, 98% have an undetectable viral load. In Australia, we're not a heterogeneous population. We're not the same. The association that I work for has a membership network of the Positive Aboriginal and Torres Strait Islander Network, the PANA, Asian Network of Australia. We have the National Women's Network. We have the Heterosexual Men's Network. So Australia, like other countries, it's a diverse population. But those statistics I gave in Australia, of course, are nothing like what's happening in the region. So in Australia, since the beginning of HIV, about 6,000 people have died. If you contrast that to Indonesia, for example, 26,000 people have died since the beginning of the epidemic. And also in Papua New Guinea today, we have, or UN estimates in 2020 said there were about 50,000 people currently living with HIV. That's enormous statistics in the region. And underestimates. I have been there, so I think it's an underestimate. Just a couple of other comments that I can get in by way of introduction. The UN rapporteur yesterday used the imagery of threads and weaving something together. I was waiting for him to say there's a red thread, and that's HIV and bloodborne viruses that's impacted on our communities everywhere. So I'm going to go back to him and suggest that he puts that in the next talk. Also the image of the quilt, which was the biggest expression, public expression through many countries about the losses that we experienced in the early years of the HIV epidemic. Comments on what we know through the data. Professor Adam Baum yesterday drew our attention to the high rates of suicide amongst our communities currently. My reflection on the experiences in the 80s and 90s in the eye of the storm, and yes, I was in the eye of the storm, is that the high rates of suicide amongst gay men and those who contracted HIV in the early years was enormous. I lived through that war, even though I don't like using particularly war imagery. What I take from being part of that, though, is that there were lessons learned through the HIV area. I came into a session here yesterday, and it was on protecting the rights of intersex people in medical settings through law reform. And I was just sitting there listening to something I don't have a great deal of understanding about, but I recalled that we have also learned those lessons in the last 40 years about law, how the apparatuses of power work in medical settings, medical research, science, political establishments, etc. We've had to find our way through all of that. And also how to respond to hate and vilification and what tactics we might develop to meet the pernicious problems of stigma and discrimination. So by way of my concluding comment, I want to say, I'll use someone else's words, and this is Jonathan Wolfe, who wrote a book called The Human Rights to Health. It's a wonderful book. He says, the narrative, the yet far from complete narrative of HIV/AIDS brings to light human rights issues at every turn. To name just the most obvious, these include discrimination against outsider groups, the need to confront taboo subjects, ... So I look forward to introducing the panellists here. And we are running a bit out of time, so this is the structure for the next 36 minutes. I'll introduce the panellists. I've got a couple of questions to ask them, and then they will talk for a little while. We don't have any time or facilities for a Q&A at the end. Sorry about that, but the live streaming, it's better to work this way. I will, however, try to facilitate our discussion so that we have a lively discussion about some of the areas of concern. That's me, that's my introduction. Welcome everyone, and I hope we have a wonderful session with our panellists. The first panellist is Didi Utomo, who's an Indonesian activist, founder and trustee of Gay Nusantara HIV Foundation. I had a little conversation with Didi yesterday about a couple of the things we might talk about. We have the tools to respond. There have been lessons learned from other places, including Australia, but government and health structures don't always provide in Indonesia, and you reminded us that we do still have some haters still. Didi, would you mind coming and talking a little bit about those topics? Where are you most comfortable?
You're going to sit there, right? I'll sit here.
You're mic'd up and away.
I think so. I can hear myself on the sound system.
Well, you take us away, Didi.
Okay.
We have the tools to respond.
Yeah. We know so much. You know, we've been with the epidemic more than 40 years. Even in Indonesia, the knowledge is there, and actually, community people. You know, the most common outreach workers may actually know more than the doctors. I mean, sorry, the doctors in the room. You know, no offense, because it's about our lives. For some of the doctors as well, you know, you be kind to the patient and things like that. As I told John yesterday, there's been some progress, and I guess because I'm in Australia, I'd like to thank the Australian people. You know, the example that was given in the late 80s, early 90s that we followed. In the 90s and the 2000s. But unfortunately, two things. Especially the current government is full of business people. Sorry, business people in the room. I come from a business family, but they think that, oh, the National AIDS Commission is a waste, so disband it. So it's just a sub-department within the Ministry of Health. Still okay. And then at the local level, you know, it's patchy and it varies. Some places are good. My city, I guess, you know, I mean, if I may say so, we are all right. For HIV and some STIs, at least, especially before the pandemic, we could, you know, have free, VZT. And then if you turn positive, the ARV is free. And now, in some cases, there are periods when viral load and other related tests are free. And if you have the state health insurance scheme, then if you happen to have an opportunistic infection or something, you can get free care and treatment. And generally speaking, the health providers are not homophobic or transphobic. And the problem is there's very few trans women, especially, because they run away from home, they don't have an ID card, so they cannot be part of the. So that's part of the government. But if we go, I mean, let me just tell you a story in a small town in central Java called Purworejo, where the police actually did a witch hunt of gay men, because arrested two men who checked into a Love Hotel, got their phones, got all the contacts. Witch hunt. And then they tested them for HIV. I think out of the 12 that they found, 4 were positive, and called the media. Here's the 4. And this is where bureaucracy doesn't work. We tried to get in touch with the Ministry of Health. Even UNAIDS couldn't do anything. Sorry if there's anybody from UNAIDS. I mean, I'm a friend of UNAIDS, but you know, it's a huge country. So that's the government side, and I'll stop after the second one. It's starting especially from 2016. There is a moral panic in Indonesia. People with HIV, sex workers, and also LGBTIQ plus people are seen as, I mean, in Indonesian history, we are seen as the new communists, the new bogeyman, or whatever. What is the gender-free term for bogeyman? Bogey person. The new, scarecrow. But I don't know if I should be heartened, but apparently it's also happening in New South Wales with some politicians. So I don't know. So that is the problem. And then of course in Indonesia, it's convoluted with hardline religious rhetoric. Oh, these are sinners, and that's okay. After the sentence, and for example, PrEP and U equals U. It took years, although there is now a pilot project. But it's like these people are sinners, and you let them have fun. Shouldn't do that, right? And so it's but there is U equals U is there as a pilot project, and apparently it's having community testing is working. Let's hope it doesn't. We don't go the Thai way where government said no, we can only do it, only us. I'll stop there.
Yeah, thank you, Didi. Thanks for that illustrative story, which does resonate, I'm sure, in every area. Also, your talk reminded me about the session yesterday where does it translate? Does something that works in another place translate to another country or to another region? So that's something we could talk about a bit further. Next, we have Terry Hara. Terry's information is up there. We heard from Terry yesterday in the plenary, and that was a great presentation, Terry. I've talked with Terry yesterday for the first time. The taboo subject about organising for people living with HIV is still not sorted. There's a good health system in Tahiti with access to medications, but unfortunately people living with HIV are still dying younger, you were saying yesterday. And also you want to concentrate on Indigenous perspectives and responses. Terry?
Yes, so I'm from Tahiti. It's a French territory, so we have a very good health system with all the right medicine and resources, doctors to provide that super health system. But last year we were doing our patchwork project for the people who die from AIDS, and I look at the figures about the date, the age, and then in the report they say, the doctor says, keep saying it's the same, you have the same life expectation. And I look at I do some statistics myself, I'm not a doctor, and I say, it's about 50. And in French Polynesia, the normal life expectation is 71. So I pointed that to the doctor, why this is not in the report? Why it should be an activist that point these issues? Also, like the health system, like in France, you have free PrEP. And in Tahiti, our health system doesn't want to provide free PrEP, but it says that it's one of the tools to minimize the expansion of HIV. So I have to go and try to knock on the door of the minister. And then he replied, I have to do a small note and report on statistic that is good. But this is the job of the health department, not of activists to do this type of work. So we have lots of challenges in Tahiti. One thing as well is that we are Maori. It's an indigenous community. So the difference between like when you're born and raised European, you know that when the doctors say this is your treatment, you take your treatment. For Polynesian, they have access to their traditional medicine. They can do the pound some leaves, think that this is good for the health, and then they don't take the medicine from the doctor, and they think it's okay, but it's something the health system and the doctor should take into account. Polynesian indigenous Maori, they believe in their traditional medicine, and that's why maybe they die early because they don't take the European medicine. So we have lots of challenge, and our association for HIV, nobody wanted to look after it, and for 10 years it was like closed, and I say, I need to do something, so that's why I went into that I took that task. But what?
Oh, well, what you're talking about, Terry, is really resonant also with some things that I heard yesterday. The presenter from Samoa talked about also the kind of maybe we could talk about myths that occur in certain places about traditional medicines and antiretroviral therapies, which I know happens in Papua New Guinea quite a lot.
Oh yeah, and one thing I'm trying to organize in Tahiti too is to get the people living with HIV to have their group and to help each other. But this is very difficult because the taboo is very strong. Like last year, I had a mother, 53 years old. She's rejected from her family because they say, "Where did you get this disease, mom?" You know, and and most of the indigenous people that got HIV, they feel isolated. They don't want people to know. So even in the village, they don't want to go to the local health center because they don't want to be pointed as because it's very taboo. Because religion is very strong. So if you had that disease, it's because you're a sinner. So lots of issues, and unfortunately, we have challenge and we have to find solution for all of that.
Thanks, Terry, for outlining the challenges and thinking about the solutions with us. In thinking about the solutions, I'd like to welcome Mish Pony from Scarlet Alliance, which is the sex worker organisation in Australia. Just for friends in the room, in Australia we have a structure where we're organised in some way. The Australian Federation of AIDS Organisations convenes our communities. Mish from Scarlet Alliance works with the sex worker groups. NAPWA works with the HIV positive peoples in different states and territories. We also have our groups who represent the needs of injecting drug users, etc. Similar structures in different places, but thanks, Mish. I know you're going to contribute to the conversation on something about the recent evidence about decriminalisation, and I know that's a topic that Terry was discussing yesterday. We might return to that. And the Asia-Pacific landscape in terms of sex worker organisation. Thanks, Mish.
Yes. So in Australia, the sex worker HIV response has been, a resounding success. Sex workers banded together during the AIDS crisis and developed networks and communities that were delivering health promotion to their communities around safer sex practices. And from those informal networks, more formalised organisations grew and developed. So at the moment in Australia, we have sex worker peer organisations. So that is organisations run by sex workers for sex workers in every state and territory. And Scarlet Alliance is the national peak body, and we are also a 100% peer organisation. So all our board, volunteers, staff members are current and former sex workers, and that it's that community-embedded nature of our sector that is driving the success. I think, for sex workers in Australia, the reason that we have, similar rates of HIV as our non-sex working peers, but globally that's not the case. And, we see rates that are 30 times higher in female sex workers, and it's estimated that in 2019, approximately 8% of all adult HIV infections were in sex worker communities, and the prevalence globally is 36% for sex workers. In the Asia Pacific region, we see countries that have a 20% prevalence of HIV in sex workers, in countries like Papua New Guinea. But we have studies in sub-Saharan Africa that shows that the differences in HIV transmission between a criminalised sex work environment and a regulated sex work environment, where some aspects of sex work are legal, it's a 7 times greater incidence of HIV when sex work is criminalised. And so we do know that it's those legislative barriers that also inform stigma and discrimination against sex workers that are the highest drivers of HIV transmission within our populations. In the region, we have sex worker organisations in about 23 countries. There's our regional network, which is APNSW, and so that has 47 members across 23 countries, and that includes organisations like Friends Frangipani in Papua New Guinea, Scarlet Timor in Timor-Leste, OPSI in Indonesia, Empower Foundation in Thailand, there's a Philippine sex worker collective, and there's a Fijian sex worker collective. And so wherever there are sex workers, we are organising. But for Australia, our success is really born out of that partnership approach with receiving government funding, working with researchers and clinicians in order to empower community to deliver the solutions that community has, because communities all over the world know what those solutions are to reducing the drivers to HIV, and it's about getting government on board and being supported by government, which isn't, obviously not seen throughout the world, but that is what sex workers are agitating for. But even in Australia, where we do have some near decriminalised environments in the Northern Territory and New South Wales, Victoria is going through a process. There are still some legislative barriers that are on the books that we're working to get rid of. And in New Zealand, people often talk about it being decriminalised there, but there's legislation against migrants who don't have permanent residency doing sex work in New Zealand. And so even when people do talk about decriminalisation, there is no jurisdiction yet that has what we would say is a gold standard 100% decriminalisation. But we're still facing high levels of stigma and discrimination, which are barriers to accessing physical and mental health care. There's still that discrimination from those healthcare providers. And so in New South Wales, we're agitating for anti-discrimination legislation that would protect sex workers and give us avenues for redress in those instances. Yeah.
Thanks very much, Mish. And we might return to the decriminalisation discussion later. Just if I can add by way of comment for our friends here, the work that Scarlet Alliance and our association, NAPWA, did with partners in the region. We have a sister or a brother group in IGAT Hope in Papua New Guinea.
Yeah.
In Timor-Leste, we have Estrella Plus, the HIV positive group there. We made connections with FJN Plus at the time. So this was work that was supported by the Australian government from 2005 to 2010. It is true that support by the Australian government was withdrawn in 2010. So our opportunity to kind of network and continue in the region, we've been doing on a shoestring budget. But luckily there were some announcements yesterday which give us hope that the current government understands that the regional response needs to be about health and returning to questions about health, development and human rights for all. So I hope that we can more of that. Colin, thank you for coming and talking about what's happening in New Zealand. I met Kevin on Zoom. We had a little discussion, and Kevin's wanted to talk about working with those at the margins, wanted to talk about the experiences of working with Indigenous groups in a multinational study, and also from Maori Indigenous perspectives. Thank you for coming along.
Kia ora tātou. I'm also Māori, same as Tiri, except I come from Aotearoa, New Zealand. So I really wanted to compare through research the ways that community are involved. And that's based on a couple of studies I'm involved with at the moment. And I wanted to highlight just who's involved and whose priorities it involves. Because I think research is really important. That's the thing that is, people are looking for evidence. That's the thing that governments are looking for and so forth. So I think it's quite important that people's priorities are reflected in that. So the study I'm involved with, or one of the studies is called SPOTS. It's the Sex and Prevention of Transmission study. It's updating the understanding of safe sex practices amongst men that have sex with men in Aotearoa, New Zealand. Now, that was started last year, has just been completed, so the early results indicate that, generally speaking, men that have sex with men are right up there with the practices in terms of keeping themselves safe, using PrEP and so forth. So that's an initial sort of finding from that. The research people involved, or the communities involved, include universities, researchers from universities, researchers from Māori health promotion agencies, and that's where I come in. It includes community organisations such as the Burnett Foundation, which was previously the New Zealand AIDS Foundation, Body Positive, which is another organisation of people living with AIDS, people living with HIV, and so that particular group. I'm also involved with another study, which is the one that has been mentioned, an international study that focuses on Indigenous women, supporting Indigenous women and girls living with HIV to achieve their sexual and reproductive health and human rights, and to eliminate HIV transmission. So this particular study goes across several nations. It includes New Zealand, it includes Canada, India, Nepal, Guatemala, Peru, and Nigeria. And it's at its very early stage. As you can imagine, there are these countries, Indigenous peoples coming together to find out who we are and to work out how that particular broad study is going to occur. The New Zealand study sort of pivots off that broad heading, and what we're looking at is the Aotearoa study, or the New Zealand study, corresponding to the epidemiological and cultural imperatives of Māori. So at this stage, we're doing two parts of that study, reflecting the needs of women and family. So family comes into that, and also a study reflecting the needs of men and family living with HIV. So the groups that are involved there, I might have flipped off, but anyway, community, Māori people living with HIV, Toitū Te Ao, a new organisation that's just been formed, researchers from a Māori health agency, and academic institutions supporting them. I think the way that the studies have been framed almost reflects where the power of the research has been directed from. And that's my observation at the moment. So there's a lot of power in the researchers and also within the academic institutions to drive the needs of the study. Whereas, in my view, and this is what has been reflected and what we're trying to reflect in the Indigenous study, is that it should be the priorities of the community to reflect their needs and how that study should progress. So, in other words, we need to flip the coin and try and engage that way. So that was really my key point, is that community is vital in setting. It's not about co-designing at this stage, it's about setting their priorities and then working out how to co-design the research practice. I guess that's something to
Yeah, great. Thanks, Kelvin. Some of the, if I can just also add to the discussion here, we know that gender-based violence is an incredible driver of what happens in terms of HIV. I would have liked to have been sitting here on stage with a friend from Papua New Guinea, a woman living with HIV, but migration and other issues have affected their participation, you know?
Yeah.
And I just wondered whether you had any kind of thoughts on how those kind of systematic discriminations around migration, travel, etc., impact on how communities respond, because that's what we're trying to think through.
Yeah, I think, you know, we see time and time again, you know, people with HIV, drug users, sex workers being, you know, facing so many barriers to travel, to collectively organise outside of their country. And so, you know, lots of these spaces are incredibly inaccessible. And we see that, you know, with the biannual HIV conferences that happen around Australia that are not Australia, the world, that are continually hosted in countries with very aggressive migration policies that do exclude so many affected populations. And so that does really hamper the networking and skill sharing and education opportunities for us to come together as community across borders and share knowledge with one another. Yeah.
Thanks.
Yeah, I can enlarge the scope to other Southeast Asian countries. I'll just give two examples. One, the Rohingya refugees. If you're a Rohingya refugee in Indonesia, there is no program. You know, as a refugee, there's no program. That's one. If you're a Burmese exile in Thailand, whether you're a sex worker, trans woman, gay man, or whatever, you cannot get programs. And communities are kind of discouraged sometimes to work. And this happens in many places. I mean, yesterday at the Kirby Institute, there's a third example actually. It's some people fall through the cracks because, like, you know, you might live in PNG, but near the border to West Papua, and you miss both programs. So that's we've been talking about migration and border programs for the past 30 years, and I haven't seen. I mean, if somebody has like a good example, I'll be so happy. I haven't seen any good programs.
So that does speak to some of the things that were talked about yesterday about the intersections that occur as well, you know, because the movement of people in labour throughout the region is a big thing impacting on that. Perhaps we feel a bit, you know, we find it difficult to think through ways forward, but then we have found ways forward. So perhaps could I just ask anyone to take up this question? There's a kind of paradox about coming out as a HIV-positive person. There's a paradox about that at the moment that we realise also with the undetectable equals untransmittable. And as you say, Dee, there is some understanding of that scientific knowledge within the community, but is it always accepted? Is it well known? And what strategies might there be to address that within our communities? There being practical examples from...
If I could just comment, some of it, from my perspective, is being seen to be part of who's being looked after. So in other words, if in New Zealand, Māori women are very invisible in terms of treatment around their needs for HIV. So if they don't see themselves as being included, then they're not going to respond. And so that has all sorts of ongoing impacts, and HIV won't end until those that are on the margins are included.
True. I mean, I agree with that. In Indonesia, if you are part of the key pops, you know, the key populations, you actually potentially get programs,
Yeah.
right? Except for, Rohingya refugees. If you are just an ordinary, heterosexual couple who might, we all know they could get HIV somehow. They don't get programs. And they say, well, I'm a law-abiding religious housewife. How can I get HIV? Well, from your husband, right? But that is, the government doesn't dare to actually have campaigns for everyone. Oh, it's too expensive. It's, you miss the targets and everything. And truth is, when you get to like the so-called HIV ward, that's just one example that I really know of at the Surabaya General Hospital. 50% are housewives. And then there's the semantics. Are they housewives or they also do sex work? So that's 30 years after, we still need to do that.
I think, though, we've also learned in that 30 years how the funding does affect what's going on.
Yeah.
So we know that you could only get support if you identified yourself as a key affected population group. And I was part of discussion with friends in Papua New Guinea about the difficulties of being locked into one group or another, to get attention. And Kelvin, you've talked about the kind of research bias that occurs with funding. Any ideas about the way to get through that problem?
Well, I can only speak from a Māori perspective in Aotearoa, and so our perspective is that family are involved. Family are the key, in our opinion, as being part of the solution, even though they may be part of the problem in the first instance. But at the end of the day, they are key in terms of our cultural ways of being as part of the solution. So we don't actually necessarily start with the question around, living with HIV. It's about who are you, where do you come from, all of those things in terms of relationship building. That is key in our perspective.
Yeah, so you need support work or enabling work, working with families, not only about, being HIV positive, but also accepting that, your daughter may be a sex worker or your son may be a trans woman. So it has to be combined with a program for family. Yeah. And then it works. And some of the family members who are negative can actually be champions. Yeah. We've seen that.
Can I just add one more thing too? Sorry. I'm not saying there's one way. All of the ways that are out there are good. And because we are in all those different dimensions.
Yeah.
So all of those solutions will work for one of us.
Yeah.
But there are some that don't work for others. And that's what
of course.
Yeah, okay. Look, we've only got a few minutes left. Terry, did you want to add anything to that particular discussion?
No, just like I'm not an expert in health and all this, but like back home, I'm the president of the AIDS Association. I do the quilt for the people who passed away.
Right.
So the last year, I have a student 24 years old. The year before, it's a woman 32. The year before, it's a young man 21. And I read the doctor's reports. We have the best health system. And I say, how come young people die in Tahiti? So I'm the voice for the people who passed away. And I'm the one who has, without health expertise, to say, do you think it's wrong? It's right that young people from our community die at that age from AIDS? So the health system needs to improve. We need research in our small island about AIDS. It's not, So the community is important we have a role in enhancing the health system about HIV.
Okay. Yeah, thanks, Terry and Didi, for raising up that way in which I sometimes get a bit frustrated with the enabling environment language because it tends to blend things, but you've spoken beautifully about how that enabling environment is actually established in practice.
May I add just one more?
Yeah.
This is only about Surabaya, my city. trans women case managers are actually powerful. They don't care, if they're paid just a pittance, but even the cisgender HIV patients, they feel more comfortable because they're people. I mean, look, I have nothing against nurses, doctors, but they're busy. And they go out of their ways and, spend extra time caring for, some of themselves are HIV positive, the trans women.
I think the kind of
Case
peer models of support bubbles up everywhere,
and
including here.
Yeah.
Thanks. I'm looking at this clock. Sorry, there's no time for questions, but that's beyond my
You can
power.
post questions on the apps, apparently.
We can. The app has closed down for questions, but we will be able to circulate and talk as we want
Sure,
to
of
after this
course.
session. Any last comment, Mish?
Yeah, it is about that stigma and discrimination piece that isn't part of those. You can get rid of the laws and the structural barriers, but there's still so much work to be done that's driven by community in reducing that stigma and discrimination. You can have the best health system in the world, but it's that stigma and discrimination piece that continues to put up those barriers that only community is able to solve.
Wonderful. Thank you, Mish.
Exactly on time.
Thank you, Mish.